Good evening, guys. I've decided to do show B for you, which we're gonna go over how over treatment became medicine's quiet epidemic. Okay, so we're gonna go through that for B. So please join me for tonight's discussion B. Here we go. The phrase medicine's quiet epidemic invokes a slow moving systematic issue, one that doesn't interrupt like a viral outbreak, but instead uh, permeates clinical practice through routines, decisions over treatment refers to the excessive use of medical interventions, test procedures, prescriptions that offer little to no benefit, and many even cause harm. Unlike overt medical errors, overtreatment is often invisible, normalized, and deeply embedded in the culture and economics of healthcare. Structural and cultural roots, intervention bias in clinical culture. Medicine has long valorized action, the, the impulse to do something is reinforced by professional norms, patients' expectations, and institutional pressures. In this climate, restraint can feel risky, even negligent. This bias toward intervention is especially strong in high stakes environments like emergency rooms or oncology, where when uncertainty and fear drive decision making. Training that rewards activity over uh, judge jealousness. Medical education often emphasizes procedural compliance and diagnostic thoroughness. Residents and students are rewarded for identifying rare conditions and mastering complex interventions, but they're rarely praised for choosing not to act, despite evidence that watchful waiting or minimal intervention can be safer and more effective in many cases. The this creates a feedback loop where overtreatment becomes a marker for good care. Defensive medicine and legal anxiety. This uh, this specter of malpractice lawsuits looms large. Clinicians may order extra tests or prescribe medications just in case, not because they're clinically warranted, but because they offer legal protection. This defensive posture is reinforced by an anecdotal humor, stories, and institutional risk management policies, even when data shows that such practices rarely prevent uh, litigation. Patient expectation and consumerism. In the era that direct to consumer advertising and online health information, patients often arrive with requests or specific tests or treatments. Saying no can feel like denying care, especially when patients equate more intervention with better service. Clinicians may acquiesce to preserve satisfaction scores or to avoid conflict, even when they requested care that is unnecessary. Financial initiatives and industry influences. Free for service reimbursement models reward volume, not value. Hospitals and clinics earn more from doing more scans, surgeries, prescription, regardless of outcomes. Meanwhile, pharmaceutical and device companies promote their products aggressively, shaping clinical norms and guidelines in ways that favor intervention. Even inten- well intentioned clinicians can we can be swept up in this tide. Why it's why it's quiet yet epidemic, diffuse and normalized. Overtreatment doesn't announce itself. It's not a scandal or signal catastrophic failure. Instead, it's the accumulation of millions of small decisions in an MRI here, a statin there, and collectively burden patients and systems because these choices often align with accepted practice. They escape scrutiny, difficult to quantify and address. Unlike infections or mortality rates, overtreatment lacks clear matrix determining whether a test or procedure was necessary or requires deep contextual knowledge and retro retrospective analysis. Moreover, what's low value in one case may be appropriate in another, making blanket solutions exclusive. Hidden harms, the consequences of over treatment, adverse drug reactions, surgical complications, psychological distress are often attributed to underlying disease rather than the intervention itself. This obscures the true cost or executive care that makes reform harder to justify. Patterns and red flags, cascade effects. One unnecessary test can trigger a chain of interventions. For example, a false positive imaging result may lead to biopsies, surgeries, or long term medication, all based on an initial low value decision. Regional disparities. Rates of procedures like spinal fusion or cardiac stenting vary dramatically across regions, even when population health is similar. The, this suggests that local practice norms, not patient need, drive intervention rates. Routine repetition. Patients with stable chronic conditions may undergo frequent testing or not, with no change in management. These patterns reflect habit rather than evidence-based care. Systematic solutions from the page. Reframing restraint restraint as excellence. Clinical restraint should be seen as a mark of expertise, not indecision. Shared decision making tools. Patient education and cultural shifts in medical training can help clinicians feel confident in saying no when appropriate. Aligning initiatives with value. Payment models that reward outcomes rather than volume, such as bundled payments or value based care, can reduce the financial pressure to overtreat. These models also encourage coordination and long term thinking. Tracking and feedback loops. Health systems can monitor rates of low value care and provide feedback. Give me 1 second, guys. To clinicians when paired with peer comparison and education. These metrics can drive meaningful change without punitive measures. Overtreatment is not a failure of individual clinicians, but a system of deeper systematic forces. Addressing it requires culturally humanity and structural reform, and is reimagining what good medicine looks like, not more but better. Okay, guys, I'll see you tomorrow for shows. For now, Gator Wellness. Take care, folks. Have a good evening.